Friends, welcome to my workplace at Ranaghat, West Bengal, India. Let us observe this routine Phaco under topical anesthesia. After the initial steps, capsulorhexis is going to be done at this moment, and I'm going to use a utreta forceps to do the capsulorhexis and a fixation forceps because the eyeball is moving a lot. The utreta forceps is used to pierce the anterior capsule. A capsular tag is raised. Hold this capsular tag and guide the tag anti-clockwise to do a round rhexis of about 5 mm diameter. And this has been a very satisfactory rhexis. If we can raise our scale to this level, do we need a femtosecond laser? Probably not. Now capsulorhexis is done. Now hydrodissection. 27 gauge cannula and BSS is used to do hydro. The nucleus is mobilized with the hydro cannula itself. Visco is injected. This is 2% HPMC. And now is the time to introduce the tip of the phaco needle. The machine being used is Ophth Cataract Easy Phaco machine, a very basic but very good phaco machine. And now this is aspiration of some superficial cortical lens matter. The nucleus is rotated both clockwise and anti-clockwise few times. And now with the help of the left hand, the handpiece is turned and the bevel is up towards the cornea. And now the tip is buried into the substance of the nucleus and the nucleus is chopped. This is the first chop. The nucleus is rotated 90 degree, chopped at this place. Again rotated 90 degree and the nuclei are separated along the initial crack, and this is division of the other heminucleus. And now each fragment is emulsified using ultrasonic energy, which is 60% in this case, and flow rate is 45 ml per minute. Vacuum is 450 millimeter of mercury. At this time I came out. I wanted to protect the corneal endothelium little more. Inject visco and now rotate the heminucleus nicely and go in again. Introduce the tip of the phaco needle again. And here it is. The fragments are emulsified, keeping the tip of the phaco needle right at the central part. At the center, the antechamber depth is maximum. You can be far away from the corneal endothelium as well as from the posterior capsule if you keep your tip of the phaco needle right at the center at the iris plane. This is a small bit of nucleus. It is removed first before aspirating the cortex. And now cortical cleanup is being done with the help of this Simcoe cannula in this case. In this case the side ports are 90 degree away from the main incision, so whatever astigmatism has been induced by the main incision has been neutralized by the side ports to some extent. So even if the side ports are little large, like 1.6 or 1.8 millimeter, even then it is actually helping in reducing the astigmatism induced by the main incision. And now in this case we are going to implant a Technis single piece intraocular lens from Johnson & Johnson. It's a beautiful lens, beautiful hydrophobic acrylic lens. No glistening occurs over the ears, and this is time tested, a good lens. In my opinion, one should not regret if he can't afford a multifocal intraocular lens. If he can afford this monofocal lens, and if he is willing to use spectacle, then this is a very good option for cataract surgery. Now in this case, visco cleaning is being done first by the Simcoe cannula and then by bimanual irrigation aspiration. We must devote some time, some quality time, to remove the visco, because this can cause raised intraocular pressure if a significant amount of it is retained in the capsular bag or in the anterior chamber. This is the irrigating probe of bimanual IA. Irrigation is done both in the anterior chamber as well as in the capsular bag, and then bimanual irrigation aspiration is used to remove the visco from the anterior chamber. The size of this rhexis is good. The anterior capsular rim has overlapped the optical part of the intraocular lens all around. And now the side ports are closed, hydrating corneal stroma on either side of these stab wounds. And now is the final lavage of the anterior chamber. At this time, a gentle stream of BSAs is directed towards the corneal endothelium, and whatever visco sticks to the corneal endothelium is removed. And as the last stave, the antechamber is nicely formed and the case is concluded. Thank you very much for your attention. Hope this video will help you in developing your surgical skills. Be a great surgeon and serve your patients with love, respect, empathy, and great surgical competence.